Good morning and good afternoon, everyone. Thank you for joining in the Cutaneous Leishmaniasis webinar. I'm Fumiko Hirabayashi. With Dr. Clara Van Gulik, we are going to moderate this webinar. This webinar is organized by Nagasaki University School of Tropical Medicine and Global Health, jointly by the Institute of Tropical Medicine of Nagasaki University, with cooperation of MSF, Médecins Sans Frontières, and DNDi, Drugs for Neglected Diseases Initiative. Today's webinar is about cutaneous leishmaniasis, which we will refer to by the acronym CL during this webinar. CL has detrimental effect on local communities. However, since it's not life-threatening, CL attracts little attention in society. This CL webinar has been planned following the research meeting held 3 months ago for Japanese scientists who are engaged in CL research. The aim of this CL webinar is to review CL extensively from diversified aspects and facilitate the research work. We have invited 6 CL specialists who will discuss the impact of the disease on vulnerable and displaced populations and its effect on mental health, and will also examine the knowledge gaps and share the latest up-to-date research findings. Please enjoy the webinar. We hope this webinar will be an opportunity to share the diverse aspects of CL, raise the awareness in society, and support research and development for new drugs, vaccines, and diagnostics. Before starting, I'd like to share a few housekeeping tips. Okay. Number 1, we will have today English-Japanese simultaneous translations. You can select the language by clicking on the button at the bottom of the screen. This webinar is being recorded. We will have a question and answer session after the presentations. Please write your comments and questions on the chat and specify who you would like to direct your questions to. We will try to answer as many questions as possible. Now we'd like to start. Our first presenter is Dr. Kurt Rittmeyer, who is Coordinator Neglected Tropical Disease of Médecins Sans Frontières Operational Center, Amsterdam. He has been leading many operational and clinical field research projects to improve diagnostics, treatments, and control of leishmaniasis under resource-limited field conditions. His presentation is CL in conflict situations, and he will also be introducing us to CL. Kurt, over to you.
Thank you, Fumiko. And I would like to thank the organizers for inviting me to give this presentation on cutaneous leishmaniasis in conflict. Indeed, because I had assumed that not everybody in the audience is familiar with CL, the disease, I start off with a very brief summary introduction on CL itself. CL is caused by leishmaniasis, which is a protozoan parasite, and there are in fact 20 different species of the parasite, and they may cause different diseases. The visceral leishmaniasis, which affects the internal organs and is a fatal disease, cutaneous leishmaniasis, and mucocutaneous leishmaniasis, which also affects the mucous membranes in the nose and the mouth. But what they all have in common is the life cycle, which runs between the female scent fly, which is the vector, and mammals, and it can be humans, but also other mammals like dogs and rodents. The estimated incidence of CL is between 600,000 and 100 new cases every year in 87 countries. But because it's such a neglected disease, it is poorly reported, and only an estimated 20 to 35% of the cases are reported to the health authorities. And of those 600,000 to 1 million people, 75% can have been reported from 7 countries only, and mainly in the Middle East, North Africa, and Latin America. And you can see that in the in this map. The darker the color, the more cases, and you clearly see that in the old world, it's the Middle East and North Africa that are mainly affected, and in the new world, Brazil and other Latin American countries. At the bottom here, you see some typical pictures of typical CL lesions. They develop on the site of the bite of the sandfly. They develop into a nodule with then a crust, which covers an ulcer with a raised edge and a surrounding induration. And secondary infections, they are very common. And although 90% of the CL lesions will eventually self-heal after months or years, they usually leave scars, which are often hyperpigmented. In terms of transmission, we talk about zoonotic transmission, so zoonotic CL or ZCL, and an example is Leishmania major, which has an animal reservoir, which are mainly rodents, and gerbils are an important reservoir. And the parasite can be picked up by a sandfly from an animal reservoir and then infect a human being. But the animals are the main reservoir. And because those animals are involved, it is typically a rural or suburban environment where you find this Leishmania major. There is also the Anthroponotically Transmitted CL or ACL, and Leishmania tropica is a very important one that only has a human reservoir. So the transmission of the disease goes directly from an infected human to a non-infected human by the sandfly. And we find this Leishmania tropica typically in urban environments. The presentation of lesions may also differ. For example, Leishmania major typically shows wet ulcers. These Leishmania major lesions, they usually heal within 6 months spontaneously. But Leishmania tropica takes much longer to heal, and they cause those dry ulcers, which may persist for sometimes several years. And they are very stigmatizing, especially for young women. The treatment, the standard treatment is with injections with pentavalent antimonials, and treatment often requires 21 to 28 injections. So the treatment is long, it is very painful, and it is very toxic. So that is a very unfavorable treatment, and Byron will talk about new treatment options later during this webinar. But as you can see, at day 28, at the end of treatment, there is a clear healing of the wound, and at day 70, the wound is completely healed, but you can still see the scarring, which will remain permanent. Let's now move to my main talk about CL in conflict. And some researchers, Berry and Baring-Ford, they have done an in-depth analysis of the literature to look at the association between the incidence of leishmaniasis and the occurrence of conflict and political terror. And they clearly found a correlation between high levels of conflict and an increasing incidence of CL disease. And for CL, there was they found an almost 2.5 times higher incidence in conflict years in a country when there was high levels of conflict terror. And they also found that this indication was mainly through a process of population displacement and health system deterioration. Now, what are the main factors in conflict that affect CL transmission? Population movements is an important one because due to the conflict, people are on the move and non-immune people can be moving to endemic areas. So coming from non-endemic areas into endemic areas. Infected people coming from endemic areas, they can move to non-endemic areas where the sandfly vector is present and therefore introduce the disease. There are important socioeconomic factors like poor housing and poor sanitation. Very often, municipal services like waste collection is disrupted. So there is a lot of waste, open sewage, which are very favorable for sandflies and animal vectors to proliferate. And there is the overcrowding in displaced camps, which may increase the contact between vectors and humans. And the environmental factors that can cause a high density of rodents as a reservoir host. Now, this is data from WHO on the reported CL cases between 1998 and 2018, so a 20 years period. And over this 20-year period, we see a more than threefold increase in the number of reported CL cases. But then if you look at where is this increase seen in the different WHO regions, you see that this is almost entirely caused by an increase in the incidence in the Eastern Mediterranean region. Now, if we look within the Eastern Mediterranean region, which covers the Middle East and North Africa, and you divide the countries in countries with intense or large internal conflicts like Afghanistan, Syria, Iraq, Yemen, Libya, and the non-conflict countries or countries with low levels of conflict, then you see a clear divide that in the non-conflict countries, you don't see this increase, and there's even a slowly decreasing trend in the number of reported cases. Whereas in the conflict countries, there you see the steep increase in cases, which clearly indicates the correlation between conflict and disease incidence. A first example is Iraq. Where we see the impact of the first Gulf War, which started in 1990. Before the war, there was a national program with spraying and insecticide spraying and other measures to control the disease, but those were completely disrupted during the war, and you see that results in a more than fourfold increase in the number of reported cases. All due to movement of non-immune population into endemic areas, and the rise in vector population due to poor sanitation, due to the collapse of control interventions. If we continue on Iraq, we have the first Gulf War, but you see a same pattern during the second Gulf War, which started in 2003. And even a stronger effect during the Islamic State in Iraq, which started in 2014 and resulted in an almost tenfold increase in the number of reported cases. Another important example is Afghanistan. CL was almost eradicated in Afghanistan in the 1960s due to extensive DDT spraying campaigns for malaria, but also for leishmaniasis. But then in the 70s, the country came into a situation of decades of civil wars, resulting in mass migration, displacement, poor housing and sanitation, a lack of treatment and control measures, and spreading to new areas. And a study done by Rayburn indicated that during the intense warfare in Kabul, in the year of 1996, there was a 12% CL incidence in Kabul. So 12% of the population of Kabul developed CL. And at the moment, Afghanistan is considered the country with the highest estimated number of CL incidents in the world. Only 20 to 40% of cases are reported annually from Afghanistan, but studies have indicated that the true incidence is more than 5 times higher, with between 130,000 and 220,000 cases every year. So apart from the high background incidence in the country, we also see frequent outbreaks, especially in cities with large displacement and poor sanitation. In Kabul city, a survey showed that in 2001 that 3% of the population had active CL and 22% had scars. So that means past previous CL. And in Faizabad, they found 8% of the population with active CL and 8% scars, which is an indication that it is a recent introduction of CL in that city. From Afghanistan to neighboring Pakistan is I would say an important implication of what happened in Afghanistan, because in 1997-98, we saw a large outbreak of anthroponotic CL in Afghan refugee camps in northwest Pakistan, where at that time 45% of the refugees developed CL. And what had happened is that Afghan refugees had introduced anthroponotic CL into Pakistan, where ACL was previously not endemic, but where the sandfly vector, Phlebotomus sargenti, is widespread. So they introduced the parasite in an environment where the vector was present and thus could further transmit the disease. So that resulted in local transmission and outbreaks, especially in the regions near the Afghan borders, where a lot of the Afghan refugees resided, with a high prevalence of CL, but also in bigger cities that had a large influx of CL, like Quetta or Peshawar. A more recent important example of CL in conflict is Syria. Syria has always had a very significant incidence of the disease, but also had very functional control programs. But you see that since the start of the war in 2011, there is a rapid increase in the incidence. the country. And that is very much related to disruption of healthcare delivery in the country. The devastating civil war has destroyed, intentionally targeted and destroyed health facilities. So more than 55% of the health facilities in the countries, they are destroyed or seriously damaged, and therefore no longer or only partially functional. About 70% of the healthcare workers have fled the country, and more than 900 medical professionals have been killed due to the violence. And because of those gaps, they were filled by volunteer health workers, which is very important in trying to provide continued services. But many of those volunteer health workers, they lack the medical expertise to appropriately diagnose and treat the disease. And of course, during the war and the violence and insecurity, medical supply lines were strangled. So it was very difficult to get drugs into the country and distribute them in the health facilities. And here you can see some results of complications as a result of delayed treatment, where the disease gets uncontrolled and with massive lesions, which are very difficult to treat and which leave a lot of scarring afterwards. The increased risk of transmission. Well, the dynamics of the war in Syria, they created a perfect mix for the proliferation of the Leishmania parasite and the sandfly vector. Sandflies, they can easily breed in the cracks and the debris of the destructed houses. They breed in the rubble and the uncontrolled waste that is left. Reservoir hosts like rats and other rodents, they also breed and or live on the uncontrolled waste and sewage that is left behind. And there is increased contact of humans with the vector due to overcrowding in cities, in displaced camps, with increased contact between sandflies and humans. So it's very easy for, especially for the spread of Anthroponotic CL in those circumstances, which resulted in outbreaks. Here you see a timeline of the distribution of CL in the Syrian governorates. That before the war, CL was mainly constricted to the northwestern governorate of Aleppo, hence also the name of Aleppo boil, a very traditional name for CL. But due to displacement in the civil war, and we talk about 6 million people that were displaced within Syria, the disease was introduced or spread to other regions of the country. But apart from this internal displacement, there is also the diaspora, the refugees, and there's at the moment 6.6 million refugees that have settled mainly in surrounding countries, Turkey, Lebanon, Jordan, Iraq, and in Egypt, where they have also further transmitted the disease, and where we have also seen outbreaks in massive refugee camps. Now, what can be done in those circumstances? And here an example of an important disease control intervention is to provide diagnosis and treatment. by which you can control the human reservoir of the disease and control the disease. And yeah, an important intervention in Syria is provided by the NGO Mentor Initiative, who, apart from assisting existing functional health facilities with training and drugs and diagnostics, they also provide mobile clinics in areas where health facilities were no longer functional, to fill those gaps. And with fully equipped mobile teams, they were providing diagnostic and treatment services to communities and to train qualified and volunteer personnel, and did some data collection. Another disease control pillar is vector control, and this can be done by indoor residual spraying, by providing insecticide impregnated bed nets, and by environmental management to reduce or to control the breeding sites of the scent flies and the rodent vectors. Those interventions can be successful, but yeah, we see very important challenges to implement those disease control interventions in conflict situations. First of all, due to the conflict itself, the widespread fighting and insecurity, and yeah, it has proven that in Syria, it is a very high risk to provide community-based activities because you may be targeted by violence. But also the rapidly changing situations that sudden mass population movements make it very difficult to plan your activities and to respond to population movements. There is the environmental factors. Yeah, if waste and rubble is not being controlled, then yeah, any vector control will be very difficult. And talking about yeah, spraying or insecticide treated nets, we're dealing with a population that has been a victim of chemical warfare. So hence also their fear of chemicals and insecticides. So many people were also yeah, refusing to have their houses sprayed because of the fear of what they had been exposed to before. Then there is the very limited and difficult access into Syria and out of Syria. So for people from outside to get into the country, to provide training and program management, but also for Syrian health staff to go out of the country for training courses. So that meant that yeah, those programs have to be managed remotely, which makes it more difficult to properly monitor what is happening, to implement quality assurance, to organize logistics. The lack of entomological knowledge in these circumstances also made it more difficult to decide what would be appropriate vector control strategies. And the lack of medical expertise, yeah, for implementing a diagnosis and treatment. So, in conclusion, what we have seen as yeah, the direct and indirect effects of conflict of CL, that we see a strong correlation between the emergence of CL and conflict. And that is directly related to transmission and infectious of disease. So the displacement of non-immune persons from non-endemic areas to endemic areas. The displacement effects, so displaced people transporting the disease into new areas. Second, the access So that is the insecurity itself is restricting access to the affected populations, but also from access from patients to healthcare facilities. The lack of medical facilities, which are partly destroyed and can no longer provide services. The medical brain drain, sorry, the medical brain drain and collapse of medical education. And due to the collapse of control interventions, which created very favorable conditions for scent flies, for host reservoirs, rodents, but also in displaced camp situations, the spread of human reservoirs, and all that is resulting to a high morbidity of CL in conflict situations. Thank you very much.
Thank you, Kurt, for your wonderful introduction to CL and presentation on how CL affects humanitarian missions in conflict situations based on your long and abundant experience in the field. I believe people have a lot of questions for you. So next is a joint talk on CL in mental health by Professor Lisa Dikomitis and Dr. Helen Price from Keele University in UK. Professor Dikomitis is Professor of Anthropology and Society of Health, leading the Institute for Global Health. Lisa is a pioneer in new and transformative ways of conducting interdisciplinary global health research. Dr. Helen Price is an associate professor in parasitology in the Center for Applied Entomology and Parasitology with over 20 years of experience working on the kinet-plastid parasites. Lisa and Helen, over to you.
Thank you. So it gives us great pleasure to introduce you to Eclipse. This is a four-year interdisciplinary global health programme that has been awarded £4.6 million by the UK's National Institute for Health Research, or the NIHR. And Eclipse stands for Empowering People with Cutaneous Leishmaniasis, Intervention Programme to Improve Patient Journey and Reduce Stigma via Community Education. This programme is co-led by myself and Professor Lisa Dikomitis. In this talk, we'll first introduce the main features of the Eclipse research programme, and then we'll focus on mental health and CL-related stigma.
Good morning, everybody. Good afternoon. Eclipse is a large global health family with teams in Brazil, Ethiopia, Sri Lanka, and the United Kingdom. And the beauty of Eclipse is the interdisciplinarity of the project. We are a team with over 60 members, including anthropologists, parasitologists, dermatologists, psychologists, sociologists, public health specialists, artists, family doctors, communication specialists, and so on. We are introducing each other to new research methods, new research cultures, and we are forging innovative interdisciplinary ways of researching CL. Now, working with researchers from different academic disciplines is important to us. To date, a lot of the CL research has been single disciplinary. For example, parasitologists focusing on parasite biology and drug development, or health service researchers exploring, for instance, barriers and facilitators to treatment, or anthropologists focusing on sociological issues. Now, it's important before we go on to make clear that there is no lab research in the Eclipse program. All research activities take place in the CL-affected communities. And let me also say very clearly that there is, of course, nothing wrong with such disciplinary focused research. Very, very important, because we build on that. But now, over to the aims of the Eclipse program. These are to explore and improve the psychosocial aspects associated with CL, to reduce the burden of stigma and the effect of that stigma on individuals, on families, and indeed on whole communities, and to capture the patient journey in its entirety, from diagnosis to treatment, to better identify where are the gaps and where are areas of strength. To achieve these aims, we have 3 interlinked phases in Eclipse. First of all, we want to explore how CL syndemics exist in each country. We will explain what syndemics mean a bit later. We will do qualitative fieldwork, long-term ethnography, participating and observing in the communities, interviews, focus groups, and other forms of participatory and creative methods, as well as quantitative work via surveys to measure stigma. These findings, phase 2, will inform the co-production of culturally bespoke interventions. Public health interventions will be community-based and serve to raise awareness or to reduce stigma, while another intervention will be a context-bespoke training package for community health workers. And finally, these interventions will of course be evaluated to determine their usefulness and effectiveness to individuals and communities, and to see if they can be rolled out and implemented in other CL endemic areas. We are now starting phase 1. So we do not really have data yet, but we still have a lot to share with you already. We established the teams and the community engagement is very well on its way. Over to Helena.
So the 3 countries in which we work, Brazil, Ethiopia, and Sri Lanka, offer us very different CL realities in terms of socioeconomic, political, cultural, and health service factors. So Brazil is known as an upper middle income country, and CL has been endemic in the country for a very long time. Public health campaigns on identification of the disease and preventative measures have been run, and we believe that awareness is quite high in the local communities. As you can see from the first picture for Brazil, there is a dedicated leishmaniasis centre in a highly endemic region of Bahia in the north of Brazil, and we'll be working very closely with the staff at this centre. So for Ethiopia, this is quite the opposite. So it's classed as a least developed country, and while it also has a history of CL, there are no official numbers or no accurate numbers concerning the cases, as it's not mandatory to report CL. And awareness of this disease is believed to be very low in the country and is coupled with stigmatization of those that have lesions. Hospitals for diagnosis and treatment often involve traveling very long journeys, and coupled with the costs of the treatment and the missed work that people have, mean that people tend not to seek biomedical treatment, but rather turn to home remedies or traditional healers. And we should point out we're very concerned at the moment about our team in Mekelle, as the Tigray region is at the centre of a civil war in the country since November. Moving on to our third country, Sri Lanka. This is a lower middle income country, and this offers a different CL reality again. So unlike the other 2 countries, CL is quite new and represents an emerging public health issue. And the first internally transmitted case was reported in 1992. And it's now required to officially report CL cases, but given its relatively new presence, the awareness among the health professionals and in the general population is quite low.
Now, for a project like Eclipse, where we are working with so many different communities in different cultures, each of which might have their own needs, challenges, and nuances, it is extremely important to engage robustly with community members and seek to gain their acceptance, to gain their trust by collaborating with community members at every stage of the research process, so that we can really co-produce the Eclipse interventions. I fully realize that decolonizing is a trendy word now, whether that is an educational curriculum or decolonizing research methods or decolonizing literary prizes, or in our case, decolonizing global health research. But it is important, and we are committed to move away from the idea that the ways of working and thinking that originated in the global north or high-income countries would be the correct or the best ways. In Eclipse, we aim to privilege the knowledge and methods of those who have been typically marginalized in CL knowledge production, both the communities affected by CL, but also researchers based in the global south. It is the local voice that needs to be the loudest. Decolonizing global health research involves working with community members and allowing them to influence the direction of research in a way that they see useful and beneficial. And as part of that agenda, Eclipse not only works in, with, and for communities, but is also committed to the idea of South-South collaboration. So in fact, our Ethiopian colleagues working directly with Sri Lankan and Brazilian colleagues, to give an example. We all work together to share knowledge and find solutions to the common CL problems. By encouraging the sharing of knowledge and practices of each culture and country, they can position themselves and be recognized as experts on the problems they face. Now, we are, of course, mindful of challenges to work in such a decolonized approach, and to overcome them as much as possible, we are constantly ensuring that community members, as I said, guide the project. Our ethos is no research about us without us, and us being the community members. And indeed, it is a phrase put forward to us from a community member. This is why it is essential to stress that the community engagement looks very different across each country. Over to you, Helen.
So public engagement and involvement in the Eclipse project is a double strategy at community level and at the regional and the national policy level. So community level groups take the shape of community advisory groups, and these are situated in our field sites, which are often at the village level. And they comprise mainly of people with CL, community leaders, traditional healers, and religious leaders, as well as other community members. And we convene the community groups at regular intervals, and we seek input and make joint decisions about different aspects of the Eclipse project. The second part of our engagement strategy is based around the policy level groups. And these groups are at an urban, national and regional level. And these target primarily the stakeholders who are able to bring about policy change in the Eclipse regions and beyond. And these include clinicians, public health officials, religious and municipal leaders, NGO representatives, regional health officers, and ideally also people with CL to have that insider perspective. And the goal of these communities of practice, which we call them, is to discuss and develop strategies of how we can use what we're finding in the Eclipse communities to promote policy change. And the aim here is to cascade the Eclipse findings and the Eclipse interventions upwards to policymakers in other regions of the country.
The Eclipse work is underpinned by theoretical concepts from medical anthropology. And the first thing we need to be clear about is that we strongly adhere to the biopsychosocial model. So in contrast to the biomedical model that really sees disease and illness as a pure biological event, we regard CL at the intersection of biological factors, physical symptoms, the toxic treatment, the lesions, the scars, the psychological factors, mental health, self-esteem, confidence, and the social context, poverty, the impact of CL on social relations, inclusion or exclusion from communities. Now, from this perspective, therefore, stigma related to CL is not inherent in the condition itself, but stigma stems from people's beliefs, attitudes, behaviors, and responses. These are always shaped by the social-cultural context in which the disease occurs. For instance, it's clear from the literature on CL that whilst in a country like Colombia, CL scars are highly stigmatized as they have political connotations associated with guerrilla fighters in the jungle, or in Turkey, scars are sometimes considered to be a beauty mark, especially by the older population, the literature shows. And in Saudi Arabia, the literature shows, CL scars are often referred to as little sister. Now, these examples demonstrate that we should not start research with a taken for granted assumption that CL is indeed stigmatized in precisely the same ways across cultures and societies. It is crucially important to take into account such cultural meanings of CL because they have very real implications in people's everyday lives on both a personal level, for instance, whether somebody chooses to seek treatment or not, but also on a policy and health system level. Do policymakers choose to put resources and services available for CL? So how will the Eclipse team research the different forms of CL-related stigma?
So we use a framework from medical anthropology, the syndemics approach. This was developed by medical anthropologist Meryl Singer. That a syndemic occurs when two or more diseases or conditions develop, interact, or they're sustained by broader social conditions. And syndemics involve the adverse interaction between diseases and health conditions of all types, whether infections, chronic, non-communicable diseases, mental health problems, behavioral conditions, toxic exposure, and malnutrition. And they're most likely to emerge under conditions of health inequality caused by poverty, stigmatization, stress, or structural violence. While there are many components that impact on a syndemic, there are two areas in particular that we wanted to highlight in this short presentation: stigma and structural violence. And we'll start here with stigma. So stigma is seen as a key factor in promoting certain syndemic interactions. In fact, where stigma is present, it's the primary social factor affecting disease interactions. It impacts on a psychological distress, which in turn can make a disease progression worse than it would have been without this stress, similar to the effects of depression. And two or more stigmatized identities may emerge in the community consciousness. And when this occurs, it's referred to as syndemic stigma. So these stigmas stem from characteristics, qualities, and behaviors that co-occur, such as being poor and having a particular health condition, or using drugs and having a certain disease. And the syndemic stigma is very likely to be different, not only for each of our Eclipse countries, but also for different groups of people living in the same community.
The second component is structural violence, first coined by the anthropologist physician Paul Farmer, and you can see his books on the slides. Despite what the name suggests, structural violence has nothing to do with physical violence, but rather acts as a metaphor for structural injustices and inequalities. Structural violence allows us, it's a way of thinking about health and access to health care, determining who gets what, who has access to what. It's established, this access, by structures in place, not any one person. So it is often unconscious or accepted as normal with historical, political, and socioeconomic origins. Structural violence also plays a role in who is stigmatized and why. The effects of structural violence are poverty, discrimination, stigmatization, and this in turn, of course, can cause significant stress and mental health comorbidities. Such psychological distress has very serious health outcomes, even to the point of being associated with, for instance, a more rapid disease progression. Structural violence is embedded into the cultural, political, and economic realms of each society. Conditions like CL are not infecting and affecting populations equally. In fact, those suffering from some form of social inequality, commonly poverty, are most at risk.
So we are now starting the Eclipse fieldwork to explore this CL syndemics. How does CL interact with mental health comorbidities and stigma? And we'll examine this with both qualitative and quantitative social science research methods. And the qualitative studies include ethnography or participant observation, semi-structured interviews and focus groups, and community workshops. And the quantitative studies will include a large questionnaire study to measure disease awareness, individual and community level stigma, quality of life, anxiety and resilience. And these survey tools are adapted to each context as these need to be culturally appropriate.
So in summary, research indicates that CL affects the mental health, social status and quality of life of those infected, meaning that we anticipate possible and potential comorbidities with CL in the form of depression, fear, anxiety, social isolation, and diminished quality of life, as the literature is also showing. However, it is important that we do not take the form of stigma for granted. Literature on CL mostly refers to this kind of stigma form: self-stigma, also called felt stigma, enacted stigma, that's discrimination imposed by others, discrediting stigma, courtesy stigma, and so on. So these different types of stigma are, of course, useful analytical concepts. However, in Eclipse, we are also very interested in an intersectional approach to stigma, how to understand stigma that arises from social, cultural, political, and health system interactions that lead to the suffering of a person with CL. And really understanding that complex interplay between those can lead to, indeed, context bespoke and appropriate public health interventions to improve the lives of people with CL.
So we would like to thank the NIHR UK Aid for our funding. And if you are interested in learning more about Eclipse, you can check out our website, follow us on Twitter or email us. So thank you very much.
Thank you, Lisa and Helen, for introducing your Eclipse project, which is very stimulating, with a lot of aspects and information of CL new to many people. We are looking forward to hearing the future progresses, new progresses of your research soon. Okay, now our next speaker is Dr. Izam Benis from Morocco. He's medical doctor, biomedical sciences, leishmaniasis control programs researcher at PET Regional Directorate of Ministry of Health. His presentation is about CL in women and children. This is another very important area in which CL gives serious impact to people. Izam, over to you.
Thank you. Again, thank you for your invitation. I will continue by discussing some specificity linked to CL in children and women. And the main plan will focus on some CL burdens that contribute to the complexity of this disease, with an overall aim of this presentation to raise some questions suitable for further research about the knowledge gaps. Definitely, as presented before, CL is a worldwide problem. And in the Eastern Mediterranean region, there are many cases, more than 74%, with 20% in the America region. And the main problem is the underreporting. Why this underreporting is important? It's because there are many of people who are not users of health facility. And this is why we have a problem to define the amount of percentage of children, which is not accurate for overall countries, because we don't know the right amount of population affected every year by CL. We have estimation, but it's not accurate. But the trend, the general trend, is that CL in children is overestimated, and we have more affected population between 0 and 10 years. The second lesion is more frequent, up to 75%, and the partial lesion represents a third of the cases. Why it seems exposes the children? Because the immaturity of this infant immune system and the absence of prior immunity to the parasite by absence of exposure to the vector are potential contributors to finding high rate of infection among infants and also young children, specifically living in endemic area, but also who travel to this endemic area. Another condition is the malnutrition that is commonly observed in developing countries and is associated with an impairment of the cell-mediated immunity, the phagocytic function, the complement system, the antibody concentration, and that makes child or the children in general more vulnerable to the infection. So, attender or not, the health facility depends also on the caretaker's consent and the awareness about CL scars and their potential damaging about tissue as consequence. For example, in the localized cutaneous leishmaniasis form, the balance between treating or not is challenging. What is the right decision to take compared to the adverse events of the classical or conventional treatment standards that existing? While in the America region, the increase of probability of relapse with notification of cutaneous leishmaniasis clinical forms make the choice to treat as hypertension more accepted, even if there are many other side effects. But everything depends on the Leishmania species and also on the treatment advance available. So there are more females affected by CL in the area where, for example, Leishmania tropica is dominating, and this is the commonly constated in the Eastern Mediterranean region, while in the America region had to show more male affected within big difference between Leishmania species involved. As you see, this picture is from a study published in 2017 titled The Mosquito That Destroy Your Face. It was done with my mentors, Professor Marlene Bollard and Professor Vincent de Brouwer and other colleagues in Belgium and Morocco. And you can predict the huge damage that a considered self-healed disease could produce in young, non-married women in terms of dermatological scars and psychological suffering. And the main results that the woman's CL prevalence is also a huge underestimation. And we have many questions that we don't have answer yet. For example, how many persistent scars due to this disease in women? Which women groups suffer more due to this indelible scars? What appropriate CL management strategy could help the suffering groups? So I want to discuss also the particularity of pregnancy that lead to two controversies. It could be explained by Leishmania species, but it could be also explained by other things. For some research done in Colombia and Israel, we have occurred spontaneous cutaneous leishmaniasis in pregnancy period without having any complication, without or with treatments like local therapy or sodium thiogluconate, without also any teratogenic or phototoxic effect. But for another study from Brazil, they found that the lesions were atypical with exophagic larval lesion. The rate of the cure was not successful 100%, it was just around 85%, with the high rate of preterm births and stillbirths, which arises also another question: is pregnancy protective or not against CL? And we need, of course, more and further research in this area, in this specific group. So, increased awareness about social burden, as explained by the previous presenter, by CL stigma that is not equal and not similarly expressed everywhere. And we should not let us to forget that there is a concomitant other kind of burden that impact the psychosocial state and could worsen the life of CL holders with their families. For example, for some Leishmania species involved and the level of exposition to sunlight due mainly to daily life or travel activity that could influence the predominance of CL in male or in female. And this trend is also easily understood when we compare CL in children to CL in adults. And how to assess this burden is commonly admitted to estimate the burden disease by quantifying DALYs and or QALYs. But the disability adjusted life years for such CL disease was quantified as so low, 0.5. Compared to other skin diseases, it's subject, of course, of huge critique. While we have this underestimation, and what we can do. So researchers do many research about that, and to correct that, they want to highlight that the realistic burden for CL could be composed by 10% of active CL as incidence versus 90% of inactive CL as prevalence. And the psychosocial burden, this measure depressive disorder, as could contribute to 70% of individuals with both active and inactive CL. And the experience or the result of this psychosocial morbidity could range from a subclinical distress around 50% to clinical disorder around 20%. When we do another calculation, we are not just in the first burden, we are talking about 38 million of prevalent patients with 2 million persons each year, which is now it's dependent on the researcher. You could make the right or the left choice. You can go with just the official administrative statistics to declare that we have just 30,000 disfiguring and deliberate scars every year in female. But also you can go with this perspective of psychosocial burden and complexity of this disease with prevalence, huge prevalence, and we estimate that 400,000 disfiguring and deliberate scars for each year attend female women over the world. So moving to another burden, which is called biomedical burden. The final outcome of Leishmania infection is an immunocompetent person, results from some interaction. And this interaction happens between the host gender, the immunity state condition, the virulence of Leishmania species, and the biological factor. Outside, of course, of any high level of exposition risk, increasing the sample frequent contact and bites probability. And like in vitro studies, we dismount the Leishmania major based on the eosinophil infiltration conducted to male larger skin lesion, which is also constated with Leishmania tropica, but for female, And the biomedical burden was included to this biomedical factor linked to the chemokine, or the highest level of chemokine. For some biological factor, while this factor like interferon gamma had to get quite healing process in female with small lesion, this observation also was exact for estrogen, that was found being protective, while controversially the dihydrotestosterone was demonstrated as leading to male CL damage due to the increase of macrophage infection, Leishmania parasite, but also the increase of parasite load and the parasite growth. For American cutaneous leishmaniasis, clinical and immunopathological classification is also linked to species of leishmania, going from the analgesic diffuse cutaneous leishmaniasis to Leishmania cutaneous leishmaniasis to the mucocutaneous leishmaniasis, and every time you find the light type hypersensitivity present, the CD4 lymphocytes compared to the rate of CD8, and also the presence of Th1 immune response compared to Th2 immune response. So we have to do more research to understand more how these factors increase or decrease the clinical manifestation. So moving to another burden, which is the economic one, I think everyone that could understand that even if you have a strategy that provides full free of charge diagnostic and treatment for CL, the population has to face catastrophic health expenditure. And we should remember that this disease, CL, is a disease of poverty. And many women and children depend on the male head family to seek medication because there are a real lack of financial autonomy within this group. Then helping all poor people to have access to the best level of available health care adapted to their disease is the best strategy that decreases most of the CL burden. But we need to have information about unitary costs related to direct medical costs, direct non-medical costs, the indirect costs, but also information about all the factors influencing the cost results. And this is why it's difficult to do cost effectiveness analysis, because we need information, accurate information about unitary costs and specific country context, but also in year-specific intervals. And facing this lack of information, research makes assumptions and hypotheses. And as a consequence, we have unfortunately an over or an underestimation of those costs, with the rather scary of published studies about this cost effectiveness model. So many factors balance this economic burden, and we should develop more and more studies, economic studies, to catch the right perspective within choosing the best model to do this studies. I want also just to remind that the indelible scar impacts the quality of life of both CL holders, but also the near nuclear families. And the psychological damage become more pronounced after 10-year-olds and continue to increase during the adolescence and during the young adulthood until 30-year-olds. And depending on the other life factors, like being married or getting a good job or winning a satisfactory, respectful social or economic status, those factors help or do not help help to be more resilient until the elder age, where the unavoidable degradation of health starts, or in controversy, do not help to be resilient, and the impact index of CL continue to be more and more alarming. Another question arises here: how to quantify such complexity with simplified tools need also more research. Finally, getting fast adapted and effective treatment would help to get better health issue in terms of smallest scars, non-visible or covered one, with better mental health and social life. I want to discuss and to highlight the potential role of artificial intelligence in CL management, especially in women and children, that will allow being able to follow up the timely evolution of the lesion with the standardization of size vectors and the cure rate threshold, which is very problematic. Being able to predict also the CL scar's final outcome at the lesion stage. Being able to have membranes in same skin color to hide scars on the uncovered body parts, with personalization also of the makeup product. Being able also to take more accurate decisions about the mimicking CL tumors and taking better clinical device decisions, especially in dermatological area. Being able to have more positive results using innovative plastic surgery techniques and surface recovery. I will stop here by inviting you to see after the other slide that I invite you to see with the reference. It's a next representation discussing the other types of CL existing. And of course, you have here a list of reference users. I will acknowledge the Moroccan Ministry of Health support, and SARS doesn't die. This is just what I remember from my mother, Professor Marine Bola, who passed away last year. Thank you to the other professor, Professor Vincent de Brouwer, and all professors and colleagues over the world with whom I shared work, and with EDIA. And if you have any further questions or any other burdens that you want to remind, please don't hesitate to contact me. Thank you so much.
Thank you, Izam, for your presentation, which is very insightful, illustrating the challenges faced by women and children living with CL who are unfortunately very neglected. So next, we are now moving on to research in new treatments. Our next speaker is Dr. Byron Arana of DNDi, which is a not-for-profit organization headquartered in Geneva for development of new drugs for NTDs, neglected tropical diseases. He's head of Cutaneous Leishmaniasis CL since 2012 and has over 20 years experience working on clinical trials and epidemiological studies. Byron, over to you.
Thank you very much, Fumiko. I hope you can see my slides. Can you see my slides?
Yes.
Okay, thank you. So I just would like to join the previous speakers to thank the organizer for this webinar and for the invitation to participate in it. Of course, at this stage, after 3 presentations, you have already heard some of the data I was planning to initially include in my presentation. Nevertheless, briefly, what I'm going to present here is about the current treatments for cutaneous leishmaniasis, some of the challenges that we face when developing new treatments, and briefly mention about the NTD goals for cutaneous leishmaniasis in the new NTD roadmap for 2030, and the gaps better manage the patients. So, sorry. So, typically, when talking about cutaneous leishmaniasis, we refer to cutaneous leishmaniasis in the New World and the Old World. This is a classification, as many of you probably know, based on the species of leishmania causing the disease, which are different in both parts of the world. Each of these parasites have a particular life cycle involving different vectors, different reservoirs, and the clinical manifestations are also different. Some of these infections evolve to a more complicated clinical forms, such as the Leishmania recidivans, which has been associated with Leishmania tropica infections in the Old World, or mucocutaneous leishmaniasis, which has been associated to Leishmania aviana parasites in the New World. And also remember the development of PKDL, which comes as a dermatological manifestation after the infection with visceral leishmaniasis. So this slide summarizes the current treatment recommendations for cutaneous leishmaniasis. Basically, the treatment recommended is based on the clinical presentation of the disease and the species of leishmania causing the infection. Treatment recommendation goes from only observation and cleaning of the lesions in those patients with single and small lesions caused by L. mayor or L. mexicana, which, as Kurt mentioned, some of these patients, the lesions self-heal in a short period of time. Short is between sometimes 2 to 6 months. In other cases, for those patients and with lesions caused by other species of leishmania, topical treatments in patients with a small number of size of lesions, less than 4 lesions usually and less than 4 centimeters in diameter, are recommended. Systemic treatments are recommended for patients with large lesions in size or number, or lesions in face or in anatomical areas where topical treatment is not feasible, or in those patients who fail to respond or don't respond to topical treatments. Finally, there are some treatment combinations that are recommended for special cases, such as patients with Leishmania recidivans or those patients who don't respond to monotherapy. Regarding the topical treatments, just 1 second. Regarding topical treatment, the ones recommended by WHO include the use of liquid nitrogen or intralesional antimonies, either alone or in combination. These treatments are applied 1 or 2 times per week for several weeks, sometimes requiring up to 10 to 15 injections. Thermotherapy, even though it's much simpler, requires only 1 to 3 applications, is not widely used for different reasons. The efficacy of this treatment is variable and in most cases around 70%. In relation to systemic treatments, we keep using the same drugs that were initially developed for the treatment of visceral leishmaniasis. No drug specifically targeting cutaneous leishmaniasis has been developed. What we are using is what we inherited from the treatment of visceral leishmaniasis. Antimonials, either meglumine antimoniate or sodium stibogluconate, are the more widely used, despite their toxicity, low treatment adherence, and difficulties to administrate. Treatment consists of 20 to 30 intramuscular or intravenous injections. More than half of patients develop electrocardiographic abnormalities, and many of them also develop liver or enzyme alterations, and also other projects related to gastrointestinal problems. Efficacy varies from 50 to 90%, depending on the species of leishmania causing the disease and the clinical presentation. Miltefosine, so far the only oral drug available, need to be taken for 28 days. Nearly 60% of all patients experience nausea and vomiting. One of the major drawbacks of miltefosine, however, is its teratogenicity. Hence, women in childbearing age need to receive contraception before receiving miltefosine and up to 3 months after finishing it. Pentamidine is only recommended for infection due to Leishmania guyanensis, while the use of amphotericin B liposomal is limited due to its cost and is mainly used as a rescue treatment. So as you can see, there is a real gap, and we need for short, safe, efficacious, and affordable and field-adapted treatment for cutaneous leishmaniasis. Having said that, as you can imagine, there is a lot of room for improvement looking at the current treatments available. We could, for example, aim to improve on efficacy and raise current cure rates, which goes from 50 to 7%, and aspired for a cure rate above 90%, for example. We could also aim to developing safer treatments and reduce the adverse events associated with current treatments, or reduce the length of the treatment to only from 2 months to, let's say, 2 weeks, which in some cases, this is negatively impacting the treatment adherence of this patient, because it's impossible to be for the patient coming to the clinic for 2 to 3 months, let's say. Developing a new treatment, however, is challenging, and the whole process should be guided by the target product profile and the preferred characteristics that we would like to see in our product. For example, at DNDi, we would like to develop an oral drug aiming to treat all cases of CL worldwide. However, based on the experience of current available drugs, we know that there is a high variability in the sensitivity of different species of Leishmania to any given drug. In fact, this is one of the reasons why current recommendation treatments are based on the clinical presentation of the species of Leishmania causing the infection. Similarly, we would like to develop a treatment which is safe enough to be used in all populations. However, having a drug safe enough to be used in pregnant or lacting women, in children, or in patients with different comorbidities is not an easy task and require extensive studies, both at preclinical and clinical stage. In the ideal world, we would like to develop a treatment which can easily be dispensed at peripheral level or requiring a reduced contact between the patient and the health provider. But again, finding a compound which fulfill all these characteristics is challenging and not easy task. We still don't understand all the mechanisms involved in the parasite survival and the host control mechanisms to allow us to develop a drug, for example, aiming to prevent the development of Leishmania recidivans after infection to Leishmania tropica, or the development of mucocutaneous leishmaniasis after Leishmania aviana infections. So as you can see here, there are so many challenges, and perhaps as an old saying goes, one size doesn't fit all. So one final comment here is just to emphasize that all these preferred treatment characteristics are the one that perhaps regulatory authorities and researchers might agree. But so far, there are just very few studies showing what are the preferred treatment outcomes from the patient perspective. And perhaps this is something that we can learn for studies or for projects such as the one described by Helen and Lisa before. Given the difficulties and cost to develop new treatments from discovery to lead optimization and from here to registration, and also because, as mentioned before, one size doesn't fit all, different paths are being followed in the efforts to develop better treatment for cutaneous leishmaniasis. Some groups are looking at using drugs which are already in the market for the treatment of other indications. For example, there are several studies that have evaluated the use of antifungal drugs such as itraconazole, ketoconazole, fluconazole, etc. Others have evaluated the use of antibiotics such as azithromycin or gentamicin, and the list of existing drugs being tested for cutaneous leishmaniasis goes, and every day you see new manuscripts reporting different results of different studies. The use of combinations, as you know, is very common in other infectious diseases such as tuberculosis, malaria, or leprosy. And of course, in BL, visceral leishmaniasis, we also are using combination, for example, ambisome plus miltefosine or miltefosine plus paramomycin, which are being used for the treatment of visceral leishmaniasis in Asia or Africa. The combination of liquid nitrogen and intralesional antimonols have been also used for the treatment of all world cutaneous leishmaniasis. Other combinations, however, have been tested. For example, the use of azithromycin plus allopurinol, or antimonials plus terbinafine, or antimonials plus imiquimod. DNDi is in fact also currently testing the use of thermotherapy plus miltefosine for the treatment of cutaneous leishmaniasis in the New World. Other groups have developing new delivery systems for topical treatments, including the use of sodium nestibugluconate loaded in nano-deformable liposomals, nanoformulations, drug delivery by tattooing, or drug depot subcutaneous injections, for example. DNDi and other groups are working on developing oral NCEs. So far, DNDi has 4 new chemical entities in phase 1 and several more in the preclinical and lead optimization stage. I'm going to briefly describe later the work DNDi is working with immunomodulators, and the next speaker, Dr. Goto, will tell you about the efforts on vaccines. So, what is DNDi doing in effort for looking for new treatment for cutaneous leishmaniasis? In consultation with CL experts and other key stakeholders, DNDi developed its strategy aiming to cover some of the needs and challenges as previously mentioned. In the long term, DNDi would like opportunities to develop a topical cream for the treatment of uncomplicated CL cases, an oral treatment for patients with large or numerous lesions, or those who do not respond to local treatments, and an immunomodulator for cases where the lack of proper immune response by the host has been implicated in the severity, chronicity, or treatment outcome of the disease. We acknowledge, however, that developing any of these treatments from screening to registration will take, if everything goes okay, let's say 10 years. So therefore, in the short period of time, we are proposing to see if there is an opportunity to better use any of the current approved treatment options in combination. Following different approaches, but always avoiding duplications and efforts and prioritizing the collaboration with other groups, during the last years, DNDi has been able to advance in its CL program. In relation to improving existing tools, DNDi is testing, as just mentioned before, the combination of one single application of thermotherapy, 15 Celsius degrees plus for 30 seconds, plus 3 weeks of miltefosine. We completed a phase 2 study showing the superiority of the combined approach as compared to thermotherapy alone. Now, we are conducting a phase 3 study in 4 countries in Latin America, aiming to demonstrate the non-inferiority of the combination of thermotherapy plus miltefosine when compared with the standard monotherapy treatment, meglumine, antimoniate, or miltefosine. Results of this study are expected by middle next year, 2022. Regarding the development of topical treatments, we know that there are several groups working on different formulations. So rather than duplicate efforts, it was decided to better enter in communication with these groups to see if there is any opportunity to collaborate with them. Right now, there are several groups working on formulation based on miltefosine, amphotericin B, simvastatin, and paramomycin. Concerning oral treatment, DNDi has been working for the last 10 years, at least on the screening and lead optimization of several compounds against leishmania. So far, as mentioned before as well, 4 compounds belonging to different families have completed their preclinical development and are now in phase 1. These new chemical entities have shown to be very active against leishmania strains causing both visceral leishmaniasis and cutaneous leishmaniasis. So our plans are that as soon as the phase 1 studies are completed, to initiate phase 3 studies testing these compounds for cutaneous leishmaniasis patients in both the Old World and New World. Regarding the immunomodulators, DNDi is working in a TLR9 agonist, which belongs to a class B CpG. It's named D35. D35 is a synthetic DNA molecule which was developed by FDA laboratories in collaboration with Osaka University. It stimulates mainly the plasmacytoid dendritic cells, producing IFN gamma through activation of NK cells and monocytes and dendritic cells, promoting the secretion of AFN alpha and beta as well. CpGD35 is proposed to be used in combination with antiparasitic drugs for the treatment of complicated CL cases and PKDL. So far, we have completed the preclinical CMC studies, and we are hoping to initiate the first in human studies by Q2 this year. So now, for the last part of my presentation, I would like just to spend a couple of minutes talking about the WHO NTD 2030 goals recently launched and the difficulties I foresee in reaching these goals. CL, as probably you know, is aimed for control only. The goal is that 85% of all cases are detected and reported, and 95% of those cases treated. Using the numbers of new CL cases that have been estimated by WHO in 2010, that is translate that we need to be providing treatment to close to 0.6 to 1 million of new cases every year. Based on what we know now, the only way of achieving such an ambitious goal is by having in place a safe, efficacious, short, and easy to use treatment for all CL cases. However, as I had mentioned several times before, is not an easy task and requires a large funding to achieve these new treatments. On top of the challenges that are needed to develop new drugs, there are other challenges which even I'm not going to discuss in deep here now. However, I think it's worth mentioning. Looking at the current stage of development of potential new treatments, it seems that what we are going to use to achieve this goal probably is what we already have in place. But sadly, there are many issues with the drug we are currently using. One of these seems to be the access. As you know, we are constantly hear about shortage of anti-leishmanial drugs, the use of counterfeit medicines, issues with local registration of approval drugs. For example, miltefosine is only registered in a very few countries. There is the eternal problem of single manufacturers of these products, and many other issues related with the current drugs that we are using for the treatment of cutaneous leishmaniasis. All these issues need to be considered and addressed if the countries want to achieve the 2030 goals. There are other issues of access, which are basically access to patients to reach the treatment facilities. And many of these treatment facilities are not in the peripheral level, but at central level, which impose a big constraint for the patient to reach these treatment facilities. Other important element in this equation relates to the diagnosis of the patients. Even though there are new and sophisticated molecular techniques for the diagnostics of cutaneous leishmaniasis, they are only available at central level. So there is a need to have a point of care diagnostics. We cannot continue depending on taking samples today, send them to the central lab, and wait 2 to 4 weeks to get the results and initiate treatment. A rapid diagnostic test is highly needed if the aspiration is to detect 85% of all cases. If we are lucky and a new treatment is available earlier than 2030, let's say 2027, just to use as an example, also we need other strategies for early detection and treatment of patients. We cannot continue depending on the way it is organized by the countries. And there are some examples that have been used, for example, by MSF, using mobile clinics to look at the patients, to identify the patients in their communities and providing treatment inside. Finally, we know that, and that has already been mentioned by Kurt and others before, that only relatively 70% or less of the countries report to WHO the number of cases of cutaneous leishmaniasis. And even those countries reporting to WHO, they only report a fraction of the CL cases that are happening in their countries, and they are also report with a very delayed, sometimes 2 to 3 years. So in short, what we need is to develop a very good and a timely reporting system in order to accurate be tracking all these the advances of the goals proposed by WHO. Finally, there are other equally important aspects of the disease which are not receiving all the attention they need, but are critical to improve the management of patients with cutaneous leishmaniasis. First, the long-awaited prophylactic vaccine against CL, a topic that Dr. Goto will cover in the next presentation. The issue of mental health associated with all skin NTDs, as already mentioned by Lisa and Helen, and also by Isam. And we really need to develop better tools to understand and how this is problem, the burden of this problem, and how it's affecting the patients. The previous speakers have also talked about the displaced population. Kurt gave us a very nice picture of what is the impact of all these problems in countries like Syria or Afghanistan. And there is no, and even when we are actively looking for new treatments, all these studies that we are conducting right now are targeting mainly using patients, adult patients. So if we want to use these treatments for a special population like pregnant women and children or patients with other comorbidities, we need, once registered or before registered, additional studies, which imply more time to become available this treatment. And there is no also very good understanding to how to manage all these outbreaks of leishmaniasis that have been described before. Finally, a few words that I believe we need more research and development activities on vector and reservoirs in order to better characterize the life cycle of the parasite and hopefully to develop better and preventive treatment of interventions. Thank you very much.
Thank you, Byron, for sharing the latest information on research and development for new drugs for CL. You have been managing various CL projects with Japanese partners, and we are looking forward to a new treatment coming from your collaborations. So our last speaker today is Dr. Yasuyuki Goto, Associate Professor, Graduate School of Agriculture and Life Sciences of the University of Tokyo. Throughout his research life, Dr. Goto has been working on immunology, pathology, and molecular biology of plastic diseases, especially leishmaniasis. Today, he is talking about vaccine, which may be of great interest to many people. Yasu, over to you.
Thank you, Fumiko, for the nice introduction. My name is Yasu Goto, and I'm happy to give a brief introduction on the recent activities for the vaccine development for CL. Okay. So as Court gave a nice general introduction on leash, let me just repeat the important thing that no matter what types of leishmaniasis, the causative leishmania parasites are transmitted by sandflies, and then the delivered parasite into the mammalian host are internalized by macrophages, and then parasite can proliferate within the phagolysosome of macrophages, and then leading to the development of the clinical disease. So as Byron mentioned, so treatment can be one of the important options for control of the leishmaniasis. But if possible, of course, we want to have a nice way intervention for prevention, which can be achieved by vaccine. So this is the topic of my talk today. So someone may just doubt, their possibility or realistic, development of the vaccine for leishmaniasis. But the answer is yes, we can develop effective vaccine for leishmaniasis. because we know that the people recovered from leishmaniasis develop protective immunity against the disease, which means, there are protective immunity we can induce. Actually, that such immunity is well characterized, so-called like Th1 response, so supported by the production of interferon gamma. So along with the clinical cases, there are really nice studies on like murine leishmaniasis. So 2 inbred mice, like biopsy mice and the BRAC6 mice, are susceptible and resistant to the Leishmania major infection, respectively. But the background immune responses, especially the T cell response, are very different between these 2 inbred strains. Biopsy mice develop Th2 type immune responses supported by like strong humoral responses and a high production of high antibodies. Whereas the BRAC6 mice develop like Th1 type immune response, leading to the activation of the macrophages through interferon gamma, resulting in good control of the infection. Besides the macrophage activation by Th1 T cells, there are more targets to control the infection. So as mentioned earlier, so the parasites are delivered by their sandflies. So interestingly, they deliver the parasite along with the salivary gland proteins. And then there are great studies on the salivary gland proteins, which demonstrated that these proteins actually exacerbate the infection of the Leishmania parasite. And then their immunity not to the parasite, but to the salivary gland proteins also confers the protection against the Leishmania infection. So besides these like anti-hemocytic vaccines, so targeting parasites within the macrophages, there are another target for vaccine development. Another one is transmission blocking vaccine, which do not protect the vaccinated individual, but they protect the spread in the community. But this is also a good target for the vaccine development leading to the disease. The types of vaccine may be in common with any types of infectious diseases. CL vaccine can include live vaccine and then inactivated vaccine, so-called killed vaccines, and then subunit vaccines, which are composed of like defined protective antigen plus Th1 inducing good adjuvant. New types of vaccines are coming, but maybe due to the limit of time, so I will just explain the live vaccines and the subunit vaccines in the following slides. So live vaccines, that is like historically well practiced vaccines for CL. So Lisa and Helen talked about the stigma by CL. You can easily imagine if you have the CL region on face, you're not very happy, but you may say, okay, if you have the small region on the unexposed skin, like under the clothes, if the lesion, having the lesion prevent the having the new lesions, new CL on the other exposed skin. So that's why the leishmanization, which means the inoculation with a virulent parasite, or historically practiced. So injecting the live parasite onto the like unexposed area of the skin can induce the protective immunity in those inoculated individuals, leading to the protection against new infection. But as imagined easily, so like use of live virulent parasite are really difficult to control the virulence by the vaccine itself. So often experiencing the uncontrolled side effect. That's why people are shifting to the virulent parasite to non-virulent, avirulent parasite. The one example is the Leishmania tarantulae, which is a lizard parasite, a Leishmania species. So because the Leishmania tarantulae, the virulence is really low to the mammalian host. So some people just use Leishmania tarantulae as avirulent vaccine strains to expecting the cross protection to the other virulent Leishmania species. But we should be careful of use of this strain because recently there are some clinical cases reported caused by Leishmania tarantulae. So the newer approach is, of course, you may have heard of CRISPR-Cas. So the newer approach includes a generation of genetically modified attenuated Leishmania parasites. So by knocking out the indispensable gene, so we can generate a virulent parasite by using the virulent parasite species. Now, one of the good example, which is, I guess, presented by Dr. Hamano in the past CL webinar, is like centering KO Leishmania major. So centering is essential in duplication of centrosomes, and then these KO parasites do not proliferate in macrophages. Let me just repeat explanation of this vaccine because it's really good example of new generation of live vaccine. So centering KO Leishmania major. So sorry, this is really small, but injection of like wild type parasite cause lesion development, whereas the centering KO parasite results in a small bump of the lesion development, but basically the lesion is really acceptable level. So the next question is this KO injection of inoculation of this KO parasite can induce the protection against virulent parasite species parasites. So either untreated or the centering KO inoculated mice are challenged with Leishmania major. So there are two types of challenge infections. So the needle type, needle challenge and the sandfly challenge. In experimental conditions, people often use needle challenge because it's easier. Just inoculate promastigote using the needle and syringe. Then they monitor the protective efficacy in those like vaccinated cohorts. So here in the needle challenge experiment, so of course the untreated mice develop skin lesion by the injection with a virulent Leishmania major, whereas centering KO pretreated mice are really resistant to the infection by the virulent Leishmania major. So right one sandfly challenge, the difference is not using their needle for infection, or they just use sandfly, the infected sandfly, and then just leading them to suck the blood and then deliver the parasite through the blood sucking. So basically their virulence is, their outcome is worse by sandfly challenge than needle challenge. So often vaccine fail to give good protective efficacy against sandfly challenge. The good news is the centering KO parasite actually gave great protective immunity even against sandfly challenge compared with untreated mice. So this means the new generation, so genetically modified parasite, live parasite, can be a good choice for their new generation of vaccine for CL. Another example includes subunit vaccines. So even the previous slide demonstrate live vaccine is safe and protective. Some people just say still worried about the use of live parasite for vaccination. The benefit of subunit vaccines, of course, this means the protein plus adjuvant, so there are no like live parasite as a component of vaccine. But the benefits are not limited to that. Easier quality control and then less production costs can be achieved by subunit vaccines. So as long as we use a good adjuvant to induce the Th1 type immune responses, we can achieve the protective efficacy immunity by subunit vaccines. So people use MPL and then CpG-ODN for adjuvant. So one most advanced examples of subunit vaccines are H111F and MPL-SC. So H111F is the fusion, recombinant fusion protein of 3 components, antigen, TSA, LMSTI1, and the leaf. Then MPL-SC is MPL is a TLR4 agonist, and SC is stable emulsion, which means oil in water emulsion. So the combination of this antigen and the adjuvant really gives good protection against leishmania major infection in experimental models. So if you see the lesion development in untreated mice and then vaccinated mice, it's clear that the vaccine prevents the development of the lesion by leishmania major. This is not limited to the old world CL, and then the vaccine can prevent the development, actually suppress the development of the lesion by Leishmania amazonensis, which causes a new world CL also. Let's say, some people say subunit vaccine will not lead to the long-term protection as do live vaccines, but actually they do. So this is another example of subunit vaccine, which is the KSAC as antigen. KSAC is again, so multi-component recombinant fusion protein composed of KMP11, SMT, A2, and CPB. And then GRASC is different type of like TLR4 agonist-based adjuvant. But the combination of KSAC and then GRASC, when given to mice like 12 months before the challenge infection by infected sandfly, still gave good protection against the infection. So this is like adjuvant only treated, and then developed the region by Leishmania major infection, whereas the KSAC plus adjuvant gave protection against this type, this strain of Leishmania major. Again, so gave protection to the infection with the other type of strain of Leishmania major. So again, so subunit vaccine is a wonderful choice for the long-term protection against CL, as does live attenuated vaccine. So as mentioned earlier, so another target for vaccine development is sandfly at the time of inoculation of parasite. So this is a good work from Sheridan from NIH showing actually the bite by the uninfected sandfly. So no the exposure to the Leishmania parasite, but the exposure to the sandfly salivary gland proteins induced the immunity against salivary gland proteins, and then when challenged with infected sandflies, that kind of immunity give good protection against the Leishmania major region development by Leishmania major infection. So the idea can be transformed to the development of vaccine, like anti-saliva vaccine. So they did a research to explore the protective antigen in salivary gland proteins, and then the immunization. This is a DNA vaccine, but the immunization with one of the components of the salivary gland proteins actually gave good protection against Leishmania tropical infection by sandfly challenge. So not only to the conventional vaccine targeting a mastigote in macrophages, we can aim at development of the vaccine targeting salivary gland proteins, or we can make the fusion vaccines targeting both, salivary glands and then a mastigote to increase the efficacy of the vaccines. So before closing my talk, let me just briefly give the introduction on the different types of vaccines. So generally, vaccines are supposed to give prophylaxis against the infection. So basically, prophylactic vaccines are supposed to induce Th1 response before the infection, leading to the protective outcome. But if we can induce the Th1 immunity even after the infection, which means in patients, maybe we can use the vaccine for treatment of CL. So so-called immunotherapy can be a good options for treatment of CL because inducing immunity by vaccine, maybe we can ignore their drug resistance, and then sometimes cost effective. The vaccine is often can be less than $1 per dose, so maybe it can be the cheaper alternative for treatment of CL. So this is an example of the preclinical work by the Steve Reed's group, and then the vaccine was given after infection with Leishmania major. So no treatment actually resulted in the really bad region development, whereas giving the vaccine after infection still suppress the development of the region. Actually, this type of the immunotherapy shows some promise in clinics as well. So in this case, drug refractory mucosal leishmaniasis. So they give the vaccine, the subunit vaccine, so composed of the 4 antigen plus GM-CSF. So you can see the outcome by the vaccine. So before the treatment, they had the region, this patient had a region in nose, but the region is cleared by giving the vaccine. So finally, so let me just introduce the immunotherapy work in dogs. So the dogs are reservoirs of Leishmania infantum, so leading to the clinical leishmaniasis in humans as well. So treatment of dogs and then the control of the Leishmania infection in dogs are really important for the control of human cases. The Leishmania infantum infection in dogs gives really bad outcome, not only the systemic or visceral symptoms like splenomegaly and weight loss. It gives the skin lesion development as well, like this one. So this is an immunotherapy experiment by Leishman-11F plus MPRSC vaccine. So when the dogs are left untreated, usually 60%, 50% of dogs they don't show any recovery from the infection, they just die. Glucantin, the antimony, do not work well in dogs, and then the treatment efficacy is like this. But treatment with vaccine actually gave much better outcome compared with glucantin only. So this is one example of vaccine-treated dog. And then before treatment, the dog had really bad lesion around the eye, but it cured by giving the vaccine. So let me just summarize. So the vaccine development for CL. So as mentioned, so the vaccines for CL are realistic. So protective immunity after recovery from CL. And then again, so leishmanization are well practiced historically. So as long as we modify the vaccine, we can induce a good immunity while not compromising the safety issues. And then to do so, so new technologies are coming. So one example is subunit vaccine. The other one is like LMO parasite, which are like avirulent, but still giving the good protection. So good thing to control CL are like so there are multiple targets leading to the protection against leishmania infection. So not only like Th1 induction targeting a mastigote, we can develop good vaccine against saliva. Also, maybe we can develop transmission blocking vaccine. So by combining like their vaccine targets in together, so we will be able to control the CL by vaccine in the future. So, but the major bottleneck is the cost for clinical trials. So especially if we want to develop prophylactic vaccines, we need to recruit so many participants to show the good efficacy. So it could be realistic to develop therapeutic vaccines before prophylactic vaccines. This is it. Thank you for listening.
Thank you, Yasu, for your presentation on vaccines, which is very enlightening. Vaccines really should play an important role in controlling CL. And now we'd like to move on. As everyone is aware, we are largely behind the schedule. We apologize for the delay, but we'd like to kindly request you to stay for question and answer if possible. I'd like to hand it over now to Clara. Over to you, Clara.
Okay, thank you, Fumiko. So I too would like to thank all the speakers for their insightful presentations, highlighting the challenges, but also the ongoing research, the developments and innovative interventions to improve the overall care of people affected with CL. Try to make a very, very short recap because we've actually now been going for quite a long time since the first speaker, and we've had 5 very detailed and very comprehensive presentations. So I mean, we've started off hearing about the complex impacts of conflict and resulting displacement on transmission, infection, healthcare access and delivery, to the various burdens such as psychosocial, physical, economic, particularly in pregnant women and children, and also the need for more research and innovative solutions such as AI, as well as the urgent need for shorter, safer, efficacious, affordable, field-adapted, and ideally oral treatment, and DNDi strategy to try to meet these needs. And we also learned about a biopsychosocial approach as opposed to just a biomedical approach to improve the CL outcomes and mental health, and the importance of understanding syndemic nature of stigma in CL. And I have to admit, it's the first time I've heard of the syndemic approach. And thank you, last but not least, to Dr. Goto for ending us on a positive and inspiring update on vaccine development with the welcome words, vaccines for CL are realistic. That's great to hear. An interesting history behind it of leishmanization, as well as the current research going on, a virulent or GM attenuated leishmaniasis parasite and the concept of immunotherapy. And so thanks to all the speakers. And with that, I just want to get to the questions that were sent via chat. At the moment, we've had a few comments, but we did have, and I wanted to use that time to see if anyone else wanted to post any more questions. We do have two specific questions that's to Kurt, and I'm just going to read them directly out. So the first question is, if the patient refuses to be treated by injection for fear or religious reasons, what kind of response do you think is appropriate? And I'll go to the second one and then we can come back to that. The second one was, you talked about community fear of chemical interventions in vector control. And what would you do if the residents refused the IRS? Over to you, Kurt.
Thank you for those questions, Clara. For the first one, well, we've never experienced that that people refused injections, because in our programs, especially in conflict situations, patients are detected by passive case finding. So the patients already come to the health clinic asking for treatment. And in most cultures where we work, injections are usually quite highly valued, or more than oral treatments. So that's why we have never come across a refusal to injections. But it could be that, especially with the treatment with antimonials, that people are have fear of the painful injections. And if that is really the case, then we may consider the use of miltefosine, which is an oral treatment, as an alternative. Regarding a refusal to insecticide spraying, yeah, that was an issue in Syria, and I think what we can do is to explain as best as possible what are the effects of that intervention, be honest about the possible risks that there are, and explain those. And if people then still refuse to have their houses sprayed, that is something you have to respect.
Thank you, Kurt. And I've seen another question has popped up. It's to Byron. It says, is tape agent effective for CL treatment?
Sorry, I couldn't hear. Is what?
It says, I'm reading out the question. It says, is tape agent effective for CL treatment? Does that ring a bell to you or anyone? Or
let me see if I can read is tape agent.
Yes.
I'm
afraid I'm just reading it out because it doesn't ring a bell to me either. Or I don't know if any of the other panelists are familiar. Are you able to see the question, Byron?
No, please. No, I cannot see the question here in the panel. Yes, is tape agent effective for CL treatment? I have no idea what tape means, or fancy if there is an acronym. I really don't know what is tape.
I must say I'm not familiar with this. I don't know if there's any panelists.
I don't know if Kurt or Isam knows what tape refers to. Sorry, I cannot answer that question because.
No. Maybe it's located to the topical treatment or like that. I don't know exactly. Well, I've never seen a tape as abbreviation before. So if there are any further explanation from the one who asked this question, it could be possible to answer.
Yes, if the person who put the question might be able to just explain what tape agent is while we kind of move on. I haven't seen any specific other question, but I did I did have a very specific, I had this question for Lisa and Helen. It's you mentioned about the double strategy of public engagement, and sorry, also particularly with the engaging with the policy decision makers, and just to see about what kind of, I wanted to ask specifically about what kind of policy change was like your priority. Was it specifically regarding, is it funding policy towards CL, or is it toward ensuring that the services are more appropriately meeting the needs of CL patients by ensuring that community engagement has been involved? Just wanted to ask you a bit more about that part.
Thank you. I'm happy to take that question. I think in such a project that really starts bottom up, if we really want to do that genuinely, then the policy change that we might want to achieve will be very different in each of the context. For instance, Clara, it might be policy change around paying for transport. So we would have to work with that ministry, or it might be policy change around making the access to benefits much more, well, accessible and easy. So very often we think still in sectors of this is a health condition, so the policy change needs to really lie with the health sector. But we would hope in Eclipse that we can work across sectors. So we can't give a concrete answer to your question, but I guess it depends on what the findings are, if that makes sense. The policy change might be only educational in one setting where CL is emerging and does not yet need to be around transport or access because the services might be embedded. I know we are short for time, so I'll leave the answer there if that's okay.
No, that's great. Thank you for your answer. Fumiko, can I squeeze in one more question that has come in from the participants? And it's again to both Lisa and Helen. It's how long is the research timeline under Eclipse? The concept of CEI is really interesting. And in what aspects of research will the community be involved?
Can I take that? So it's a 4-year project, and we're already into our second year, so we have a team set up. The community engagement is a key part of everything. So we have advisory groups who we go to discuss all of the research and the methods that we'll do. And we hope that they will advise us on what's appropriate. So for example, with the questionnaires, we give the questionnaires to our community groups first to ask if they're appropriate, if there are any questions that don't make sense. And we hope that with both the village level community groups and also with our communities of practice, we'll be able to develop the interventions. So it's a really key part.
I think to add to that, the CEI strategy, which Farah asked about, is really context bespoke. So for example, the Brazil team is led by Dr. Paulo Machado and Professor Lenny Tratt, and they are working very closely with artists, for instance, around the community to engage the communities, while perhaps in the Ethiopian team, they would work with other practitioners to engage the communities. But community engagement underpins each aspect of Eclipse from start to finish. I think that's important to stress again.
I think we'll all be looking forward to looking at the different development from Eclipse program to the vaccine development, to the drug development as well, and to continue to improve the care. And I think, though, Fumiko, am I right to say that we're going to have to wrap up? And I think there was a sort of explanation in Japanese for the tape, potentially as being occlusion, but it's still not familiar to me. So I think those questions we can leave maybe aside for further clarification with the speakers later on. So I'll now like to pass on for closing remarks to Professor Kita, the Dean of the School of Tropical Medicine and Global Health at Nagasaki University. Over to you, Professor Kita.
Okay. Can you hear me? Can you hear me?
Yes.
Yes? Okay, thank you. Thank you very much for the kind introduction. And actually, I'm going to give my closing remarks in Japanese because we have the interpreter. So, okay, anyway, so TMGH、私たちのこのですね、熱帯医学グローバルヘルス研究科、本日のスピーカーの皆さん、それから参加者の皆さんにどうもありがとうございました。今日のセミナーはですね、紛争状況にしたそのイントロダクションで始まりまして、最後、最新の薬、それからワクチンですね、こういう開発まで講演していただいたんですが、今回はその通常のセミナーではなかなか聞くことができない、そういうメンタルヘルス、それから母子保健という、こういう観点からの講演で、学ぶことができました。で、リトルシスターと呼ぶ地域もあるということですけれども、実際に人は他人を見た目で判断しますので、やはりこの CL は致死的ではなくても、その人の一生に大きく影響を与える、そういう NTD です。私は1984年から2年近く、パラグアイに医療協力プロジェクトのチームリーダーとしておりました。で、そのパラグアイとかブラジルでですね、多くの CL の患者さんを見ました。そしてその時ですね、本当に有効な薬がないということを、目の当たりにいたしました。で、今日のですね、ウェビナーで、本当に状況はですね、40年経ってもそんなに変わってないんだということがよく分かりました。ただ一方、皆さんがですね、非常に多くの努力をされているということで、これは大変な希望につながりました。そして今日ですね、150名近くの皆さんが参加してくださるということはですね、非常に嬉しく思うとともに、また心強くですね、思いました。今後 CL を取り巻くですね、取り組みが少しでも進展することを祈っております。そして最後にもう一度、スピーカーの皆さん、参加者の皆さん、そして、モデレーターの木原さんと文子さんにですね、本当に感謝をいたしたいと思います。Thank you very much indeed